Welcome to this video on metabolism, focusing on diabetes, obesity, and thyroid disorders. Diabetes mellitus is a group of diseases affecting glucose metabolism. The body fails to metabolize sugars, leading to accumulation in the blood and urine, which can result in complications like coma or death due to acid-base imbalance. There are two main types. Type 1 is secondary to a malfunction of the beta cells in the pancreas. Type 2 is secondary to insulin resistance, leading to abnormal glucose metabolism. This table outlines the clinical categories of diabetes mellitus and their characteristics, including type 1, type 2, latent autoimmune diabetes in adults, other specific types, and gestational diabetes. Symptoms for type 1 diabetes include extreme thirst, frequent urination, extreme hunger, rapid weight loss, and irritability. Type 2 symptoms commonly include excessive weight gain, family history, poor wound healing, blurred vision, itching, drowsiness, increased fatigue, and tingling or numbness in the feet. Risk factors for type 1 include family history, previous infectious disease, race, and presence of islet cell antibodies. For type 2, risk factors are older age, obesity, family history of type 2 diabetes, history of gestational diabetes, impaired glucose metabolism, physical inactivity, and certain race/ethnicities. Diabetes is diagnosed through laboratory testing, as shown by the glucose meter display. Signs and symptoms include hyperglycemia, polydipsia, polyuria, polyphagia, fatigue, muscle weakness, and for type 1 only, weight loss. The goal of diabetes management is to maintain blood glucose and lipid levels within normal limits to prevent complications. Lowering A1C levels to 6.5% is associated with decreased microvascular complications. Management is highly individualized, depending on the patient's condition and ability to adhere to the regimen. Diet is the cornerstone of diabetic treatment, supported by medical nutrition therapy. Exercise is also critical for improving glucose use. Patients are encouraged to wear a medic alert bracelet during exercise to ensure safety. For hypoglycemia treatment, if the patient can swallow, administer 15 to 20 grams of simple carbohydrates like juice or glucose tablets. Follow up with a longer-acting source. If the patient is unable to swallow, turn them onto their side, administer glucagon, and call for emergency assistance if they do not awaken within 15 minutes. Diabetes medications include various types of insulin: rapid, short, intermediate, and long-acting. The dosage can be determined using a sliding scale coverage, which adjusts the insulin dose based on current blood glucose levels. Rapid-acting insulin preparations include insulin aspart, Lispro, and glulicine injections, as well as human insulin inhalation powder. Their onsets are quick, peaking within 0.5 to 3 hours, and durations are generally 2 to 5 hours. Short-acting insulins, such as regular human insulin and buffered regular human insulin, have an onset of around 0.5 hours. Their peak activity occurs between 1 and 5 hours, with durations lasting between 5 and 8 hours. Intermediate-acting insulins like isophane insulin NPH, insulin zinc suspension, and insulin detamere injection have longer durations. Onset ranges from 1 to 1.5 hours, with peaks between 4 to 12 hours and durations up to 24 hours. Long-acting insulins include glargine, detamere, and degludec injections. Glargine has no defined peak and lasts 24 hours. Degludec has a peak at 9 hours and can last for 3 to 4 days. Oral hypoglycemic agents work through various mechanisms, such as reducing glucose release from the liver, as with biguanides, or increasing insulin secretion, as with sulfonylureas. Considerations include the risk of hypoglycemia and contraindication. This table outlines other oral hypoglycemic agents, or OHAs, including DPP-4 inhibitors, SGLT2 inhibitors, GLP-1 receptor agonists, and dopamine 2 agonists. They work through different mechanisms like enhancing the incretin system, blocking glucose reabsorption, or increasing insulin sensitivity. Diabetic ketoacidosis, or DKA, is a serious condition caused by insufficient insulin, leading to incomplete metabolism of fats. Signs and symptoms can be life-threatening and include polydipsia, polyuria, fruity breath, dehydration, and Kussmaul respirations. The treatment goals for DKA include restoring normal blood pH, correcting fluid and electrolyte imbalances, gradually lowering the blood glucose level, and providing life support measures as needed. This requires close monitoring and careful management. Hyperglycemic hyperosmolar non-ketotic state, or HHNS, primarily occurs in people with type 2 diabetes due to high blood glucose levels from illness or stress. Glucose levels are often greater than 600 milligrams per deciliter. It can be precipitated by certain medications, acute and chronic illnesses, or treatments. HHNS treatment focuses on fluid replacement and correcting electrolyte imbalances. Fluid replacement is initially rapid, requiring frequent cardiovascular and lung status assessment. Small amounts of insulin may be used, and blood glucose intake and output must be closely monitored. Two other DM disorders are the Somogyi effect and the dawn phenomenon. The Somogyi effect involves rebound hyperglycemia following nocturnal hypoglycemia. The dawn phenomenon is morning hyperglycemia caused by the nocturnal release of growth hormone, glucagon, and epinephrine. Patient education for diabetes management covers many topics, including the pathophysiology of diabetes, diet and exercise, blood glucose monitoring, foot care, urine testing for acetone, identification tags, sick day rules, community resources, and travel tips. Obesity is a global health concern, with over 40% of U.S. adults considered obese, defined by a body mass index of 30 or above. It is a major risk factor for cardiovascular disease, type 2 diabetes, and certain cancers. Preventing obesity is a goal of Healthy People 2030. The etiology of obesity involves a combination of factors, including a high-calorie, high-fat diet, lack of exercise, overconsumption of food, and possible genetic predisposition. Other influences include certain medications, the American diet, stress reactions, and metabolism. A key sign of obesity is weighing more than 20% above the ideal weight. Complications are numerous and include diabetes mellitus, hypertension, hyperlipidemia, coronary artery disease, sleep apnea, cholelithiasis, cancer, arthritis, and decreased wound healing. Obesity classification uses the body mass index, or BMI, where a BMI greater than 30 indicates obesity. The waist-to-hip ratio is also a key indicator, especially for older adults, with ratios above 1.0 for men and 0.8 for women indicating overweight. Treatment for obesity primarily relies on dietary control and exercise. For patients with a BMI greater than 40 or 35 with complications, bariatric surgery may be an option after extensive counseling and assessment. The thyroid gland is regulated by TSH from the pituitary gland. It produces T4, T3, and calcitonin. Its functions include fetal development, controlling the metabolic rate of cells, regulating metabolism, promoting RBC production, and maintaining calcium balance. Thyroid hormones also affect respiratory rate and drive, increase bone formation, decrease bone resorption of calcium, act as an insulin antagonist, and exert chronotropic and inotropic cardiac effects. Hyperthyroidism is caused by an excess of thyroid hormone, which speeds up body systems. Causes include excess TSH, autoimmune reactions like Graves' disease, thyroiditis, tumors, or excessive supplemental thyroid hormone doses. Graves' disease is the most common form of hyperthyroidism, caused by an autoimmune disorder where the thyroid oversecretes thyroid hormone. Assessment for hyperthyroidism includes a health history, checking vital signs, examining the neck for goiter, observing for exophthalmos in the eyes, and monitoring respiratory effort and peripheral pulses. Also assess energy level and activity tolerance. Further assessment involves looking at elimination and sleep patterns, fluid balance, oxygenation, nutritional status, and weight pattern over several weeks to understand the full scope of hyperthyroidism. Exophthalmos, or bulging eyes, is a visible sign often associated with hyperthyroidism, particularly Graves' disease. The presence of a goiter, or enlarged thyroid gland, is another sign that can be visible on the neck in cases of hyperthyroidism. Thyroid crisis, or thyroid storm, is a life-threatening emergency requiring ICU admission. Treatment includes anti-thyroid medications, an external cooling blanket, and acetaminophen. Avoid aspirin. Close monitoring of cardiovascular and respiratory status is essential. Clinical manifestations of thyroid storm include hyperthermia, tachycardia, systolic hypertension, abdominal pain, nausea, vomiting, and diarrhea. Also look for agitation, tremors, confusion, delirium, coma, and seizures. Diagnostic tests for hyperthyroidism show elevated T3, T4, and free T4, and decreased TSH. A positive RAI uptake scan and thyroid scan also confirm the diagnosis. Management involves anti-thyroid drugs, ablative radioactive I-131, or thyroidectomy. Client education is key. Radioactive iodine 131 is not recommended for pregnant women. The client drinks the solution with a straw. Monitor lab values and report signs of hypothyroidism, such as weight gain, fatigue, bradycardia, and hypotension. Preoperative care for a thyroidectomy includes teaching deep breathing and appropriate coughing exercises. Instruct the client to support their neck with their hands when moving. Also, instruct the client on self-administration of prescribed antithyroid drugs. Postoperative care for thyroidectomy involves providing comfort, monitoring for hemorrhage, promoting a patent airway, and maintaining a patent IV. Monitor for hypocalcemia using Chvostek's and Trousseau signs, and monitor speech. Medications for hyperthyroidism include antithyroid drugs like propylthuracil and methimazole, iodides such as potassium iodide and Lugol's solution, and beta-adrenergic blockers like propranolol.